All right. So the next stop is on a very ongoing topic. I'm sure we're all excited to hear about this. It's Innovator Semaglutide in chronic weight management from mechanism to real world impact. This is by Dr. Swaraj Vadankeri, and I would like to call upon the chairpersons. We have Dr. Nagaraj N, consultant physician, diabetologist, and professor, Department of Medicine, Saptagiri Medical College, Bengaluru. We also have Dr. Venkata Krishna Rao, consultant physician and diabetologist at Synergy Diabetes Clinic in Bengaluru. And we have Dr. Preeti Shankar, consultant physician and diabetologist at Apollo Clinic, Bangalore. Welcome on stage. And we would request you to please introduce the speaker.
So, as we all know, India is the diabetes capital. Now, we are in a stage wherein we are going to become the obesity capital of the world also, if we continue or if we don't concentrate on lifestyle management. So, there are lot number of medications that are available in the market which to control our weight. So, how to manage our weight and what are the drugs that are available? I invite Dr. Swaraj Vadankeri to give insight about the Innovator Semaglutide in chronic weight management from real mechanism to the real world impact. Welcome to you.
Thank you. Thanks a lot, chairpersons, for giving me this opportunity to be here at the outset. I hope I'm audible. This is something really wonderful. Dr. Manor always comes up with some new things. This is my fourth Visha that I'm attending with him. And this is a concept wherein only people wearing the headset can listen. The other point, interesting point, I don't know if you feel anytime bored with what I'm speaking, you can just switch the channel. So you can go and see the screen there on the right hand side and you can go to the other hall. So I don't know, I will be able to see whether it is red or green. So I will know who is listening to me or rather who is not listening to me. So I don't know if it's a good thing or a bad thing. Technology helps. Yes. So, sir, the chairperson was already saying if we are not able to control, we will become the obesity capital of the world. So, after practicing 12 years of diabetes and endocrines, now I have given another space in my OPD for obesity itself. So, this is we used to talk about holistic diabetes care, where Dr. Anil sir is here. We would see retinopathy, nephropathy, all other comorbidities. So, similarly, obesity also needs to be approached in that particular angle. It is just not about your weight or your waist circumference or your BMI or your waist to height ratio or any one particular thing. There are multiple things that need to look about. Today morning we had a session. It said that we should assess sarcopenia. So the obesity is also requires a holistic approach, and that is what I am going to start in the next few days. And this is how it is going to be. So we have a in-body device which will check your visceral fat area, which is the most predominantly the kind of fat that we are seeing, and how this newer molecules are helping decreasing that visceral fat. The sarcopenia assessment needs to be done because once we put these patients on this weight loss medicines, there will be some amount of fat loss. Along with that, we are going to lose the muscle as well. So that needs to be addressed. So that is also a part of it. And then sarcopenia assessment requires a separate approach altogether. So I will not bore you with that, but the whole concept of me trying to tell is we are looking at 20 years, if I am alive by then, a different approach towards obesity and diabetes than what we are having today. So we already have newer and newer molecules which are there in the which are there for us to use, and the kind of approach and the kind of evaluation that is needed will be entirely different than what we are doing today. To put it into perspective, 2010 was when I finished my MD medicine. So at that time, sulfonylureas, metformins, that was the only thing that we were using, and insulin. Now we have first generation GLP, second generation GLP, probably we'll have third generation, fourth generation. Just like how we had sulfonylureas generation, we'll have generations of GLPs to come. So that is the newer things that are going to come into the market. So today I will be talking about these 4-5 things that are on your screen. Burden of obesity, why for this transformative weight loss, and weight loss, how it does it, how it benefits, and what is tried and tested, not what is currently available. All that glitters is not gold, all that is cheap is not good. how to use the practical things, how to use this in a practical day-to-day scenario. I think I'll not bore you with this. 1 billion people affected by obesity, some 64 are adults, 86 adolescents. This is very, very important. In the next 10 years, this 86 million people are going to be the ones which are going to be addressed, assessed and evaluated entirely differently from what we are doing currently. And the 71, so 80 plus 70 is 150 million that we are looking into. So these are the people whom we are to be looking at. These are the kind of people who will require a different set of medicine than what are currently available. So we need to be prepared for that. So the greatest number of people are come from the low and middle income class countries, wherein they do not have the access to all the newer molecules. So that is how we are going to do. So if I talk about India, 254 million people are living with generalized obesity, 350 people are living with abdominal obesity with probably a lower BMI than the Western counterparts. So these are the ones which we need to assess and approach differently. 26 million people 26 million children are living with obesity. So we all know nutrition. Earlier days when I was doing my PG, my seniors used to, one of my favorite teachers, diet and exercise counseling, fantastic, used to talk about a particular diet in one particular order. He never used to miss that order. Proteins, carbohydrates, fats. He had one particular flow, how a vegetable vendor sells the vegetables in one particular order. So he used to say the same thing. So we grew up listening to that. But what does the science say? Probably at the end of the day, probably you will not lose more than 7% of the weight with whatever diet you are following. Then we have exercise. Then we have so many other things that are there. So, but at the end, how much are you losing? Probably 10%. So you are 100 kgs, you will become 90 kgs, but still the risk persists. And if you want anything more, we had the bariatric surgery then. So bariatric surgery, high labor intensive, not easily accessible, yes, gave around 20 to 30% of weight loss. So from 170, fantastic, everything got reduced, great. But accessibility, cost and surgical risks associated, that needs to be seen. So we had lifestyle, we had surgery, nothing in between. So this newer group of molecules that have come into the market try to address this gap. So how? So from roughly, even if they say 5%, let me double it saying that you will lose 10% with a good diet and exercise. So are we, if a 100 kg guy is doing something and is becoming 90 kg, are we reducing his risk? No. But if you are able to reduce that 100 kg guy and make him, or a 90 kg guy, make him 70 kgs, that's a fantastic reduction. So you will reduce the MACE, you will reduce the renal out, you will reduce the cardiovascular mortality and morbidity. So that needs to be addressed, and that is where these kind of molecules are into the picture. So why Innovator Semaglutide for transformative weight loss? We all know about this semaglutide, the innovator. Innovator is something which has brought a particular molecule after doing a hell lot of R&D and having a hell lot of patience on it for a better outcome. So that is why this is called the innovator. Innovator is the person who first brings it. So then there are copies. So innovator versus copies. So semaglutide, it has a 94% homology to the human GLP. It has a T half of roughly around a week. It acts by the direct activation of the hypothalamus and activation in the hind brain. So it does a homeostatic regulation. Very important, the dose that I am talking here. So I am talking only pertaining to weight loss, and I am not talking pertaining to the diabetes. So when it is diabetes, the dose is lesser, but when it is for obesity, the dose is significantly higher. So at 2.4 milligrams, semaglutide does hedonic regulation, wherein it reduces food cravings. It not only reduces food cravings, it also reduces all the things that we are addicted to, especially when it comes to food. So whenever you put a big thick slice of pizza in your mouth, the cheese melts. So you kind of get what, inverted commas, pardon me for using a term which most might not like, a foodgasm. So that is what it reduces. So this hedonic regulation is very, very important in reducing the cravings. Similarly, this has been used in patients who are chronic alcoholics, because the same part of the brain is stimulated. So that needs to be controlled, and that is where this molecule plays a very, very important role. Now it has been used, even is being used in patients who are addicted to certain drugs. Basically, it reduces the cravings. So then the amount of data that the innovator semaglutide has has been extensively studied across the phase 3 programs. You have from step 1 to step 11, then you have the teen studies, then you have the heart failure study, then you have the renal study, then you have the step up increase study. That is the 2.4 milligrams was the dose that we were using, then the step up was 7.2 milligram, and the step up for obesity and step up type 2 was for the people with type 2 diabetes. So over 30 million people have been prescribed therapies containing semaglutide worldwide. So 30 million people is a lot of people. So step 3 was with intensive behavior, how they have compared across all the different studies. If, most of us are very much aware of this. Step 3 was with intensive behavioral therapy. Step 7 was with weight management, predominantly in the Asian population. Step 8 was with their own product, liraglutide, head-to-head it was done. And step 9 was in patients with obesity and knee osteoarthritis. This is very, very important. I have a patient, knee osteoarthritis. She was around 95 kgs. We started her on this. Her she wasn't happy that she lost weight. She was happy that her knee pain reduced. So she's like, whatever you have given me, it is, I don't know what it is doing for my diabetes and for my weight, but my knee pain has significantly reduced. So that is the kind of benefit that we are getting. So she was around 62 years old, 95 kgs. Probably she lost around 7% of her weight. With that 7%, the amount of osteoarthritis had reduced. So this clinically not asked, that means the history was not asked, how is your knee pain? So without being evaluated, the person is coming back and telling to you that yes, my knee pain has reduced with whatever injections that you have given. So, and step 10, reversal of pre-diabetes in patients with obesity and pre-diabetes. Step 11 in Asian population with obesity with a BMI of more than 25, and in people with preserved ejection fraction and people with diabetes and preserved ejection fraction, type 2 diabetes and obesity, and select CV was the cardiovascular outcome trial, and essence was very, very important, which was in metabolically associated steatohepatitis. So more than 20% weight loss, that is, and also 1 in 3 adults participants lost weight. 1 in 3 is a very big number. So if you are starting it for 3 people, one person is going to achieve at least 15%. So 300 kg people are sitting right in front of you on day 1 versus day 100. One person will definitely be 85 kgs. Who will be? How will be? That's a clinical response that we as doctors need to assess. So 1 in 3 is a very big number. So 3 out of 10 is a very big number in clinical practice. So that is the amount, and also more the weight to begin with, more is the weight loss, and less the weight to begin with, less is the weight loss. That is another important clinical point that we need to understand, that people who are more obese are more likely to respond, and people who are less obese are less likely to respond. So even this was in people with more than 12 years also, more than 20% weight loss, more than 5%, more than 10%, 15%, 20%. So around 37% in this people in this age group of more than 12 years, 37% of the people were able to reduce their weight by more than 10%. So now approved in India for adolescent obesity. The numbers that we showed you in the first, so these are the people who are more likely to be receiving this drug in future. So we need to address that. Of course, parental consent, less than 18, parental consent is compulsory required. So if you have a 15, 16-year-old coming to your OPD and saying, give me this drug, no, parental consent is needed. So semaglutide 2.4 is indicated in adolescents ages 12 years and above with obesity and body weight above 60 kg as an adjunct to reduce the calorie diet and increase physical activity for chronic weight management. So weight loss benefits, more than 20% of the weight loss in more than one adolescents out of 3, weight loss starting as early as 4 weeks and sustained over a period of 4 years. So 5%, 9 out of 10, 10%, 3 out of 4, 15%, 1 out of 2, and 20%, 1 out of 3. So this is the numbers that we are supposed to be remembering. These are across the step trials. So participants, so 5% is significant. So our textbooks say that even when a person who started on any particular regime and is able to achieve a 5% weight loss, lipids improve, blood pressure improve, your risk of further myocardial infarction reduces. So multiple things are there that are benefited with 5%. So in 5%, 9 out of 10. So as good as all of the patients whom we are starting is going to get benefited. So 3 out of 4 participants on semaglutide 2.4 milligrams lost 10%. So that is a significant number. So 10% basically are going to reverse your MASH. So that is the kind of weight loss. And 15% of course body mass decline with tirzepatide than semaglutide. As I told when we began, that as we start this drug, there will be newer and newer things that are going to come. So sarcopenia is something very, very important. Roughly around 3 to 4 people will have some or the other associated effects of sarcopenia. That is the ill health on the muscle. So that needs to be addressed. So very important that we assess that to begin with and see are they improving or worsening. So you just cannot start this drug and forget it. So, but if I compare it with the closest drug that is available, that is tirzepatide, it was far lesser than compared to tirzepatide. So again the same thing. If I have to come to the Indian data, n number of studies were there from STEP, Sustain, Pioneer Teens, and the Essence and the Focus. All the other, even the flow triad that included the renal data, that gave us the renal data. So all of these patients had Indian participants across the spectrum. So 40% reduction in abdominal obesity. So as a simple measure is what we can do in our clinical practice, learn how to measure the waist circumference. So if we are able to see a decline in waist circumference clinically, that is a very telltale sign that the abdominal obesity is coming. But if you are into research and want to quantify, so if you are saying 34 inches था पहले, बाद में 32 inches हुआ, उसके बाद में 30 inches हुआ, क्या हुआ? So what is happening within? So it is just not the number, right? So we need to know the visceral fat area. So that is where the gold standard is probably MR or CT, or DEXA is the gold standard. Second is probably MR or CT. But if we are able to get the same kind of visceral fat area assessment done non-invasively via bioimpedance analysis, I think that is how the future will be, wherein you need not have to send every patient for DEXA. DEXA is not easily available and costly. Whereas a BIA machine around 5-6 lakhs, you can put it in your clinic and just hold the electrodes, and that tells you your body fat area, the visceral fat area. So that tells that yes, if the patient is not responding, let us say you started 0.5 milligrams, you increased to 1 milligram, patient is not responding. So you can tell the patient, yes, this is there, we started, you improved, but still much more needs to be done. So you need to step up. So for that step up, these are the things that we need to be doing. So Asian showed an average abdominal fat reduction of around 40%. This is a great reduction. Numerically greater weight loss in Asians versus tirzepatide. When we compare the same semaglutide with tirzepatide, the amount of weight loss, the abdominal visceral fat area reduction was significantly higher when compared to tirzepatide. And 75% of the weight loss that has come in patients with, so for example, a person with obesity started on a drug, has lost 10 kgs, out of which 7.5 kgs is coming from the fat, 2.5 kgs is coming from the muscle. So we need to make this high and that less. So that is possible. Even more further, it is possible if you are incorporating more than 1 gram per kg body weight of protein and doing good amount of resistance training and not just physical activity, not just cardio. You have to do resistance training for us to have that effect. So select trial again reduce the risk, semaglutide reduce the risk of MACE by around 36% in Asian people with consistent effects regardless of the BMI and people with type 2 diabetes. Semaglutide has well established the safety profile supported by 38 million years of patient exposure since 2018. So I have told you try tested because we have data across the spectrum. So we have quite a lot of people doing these studies in India, in Asia, in Europe, and in the US. So we have data across the globe. So it is well tolerated. The only side effect that we need to observe is probably the upper GI and the lower GI rather than the risk of pancreatitis, medullary carcinoma of thyroid. I don't think so. We need to tell the patient that this is a part that we need to assess, but need not scare them that this is going to happen. The risk of pancreatitis is significantly lesser. Of course, if a patient has already had a risk of attack of pancreatitis, that needs to be documented well in our notes. Cholelithiasis was reported in around 1.6% because any treatment which causes sudden weight loss is a risk factor for cholelithiasis that we should be keeping in mind. So semaglutide has been studied for around 60,000 people across STEP, Sustain and Pioneer clinical trials. Semaglutide has a worldwide cumulative exposure of 49 million patient years across indications since almost around 8 years. So how to use it? I think most of us know. Anybody who is more than 18 years, BMI of more than 27 with one or other comorbidity, or BMI more than 30 without any comorbidities. So for obesity, I'll reiterate, for obesity, the dose is 2.4 milligram maximum tolerated dose. We have 7.2 also, but currently I don't think so it is available in India. 2.4 milligrams is the current dose that is available, that we need to be trying to go. So we have to go slow. That is very, very important. So this is how we are going to escalate. 0.25 milligram, it says that your body needs time to get adjusted, but I am not a huge fan of it. It is again personal choice. I directly start with the 0.5 milligrams for 2 to 6 or 2 to 8 weeks, and then see the response, and then step up to 1 milligram, 1.7 and 2.4 milligrams. So 0.5 for 1 month, 1 for 1 month, 1.7 for 1 month, and if tolerability is good, you can step it up to 2.4. So semaglutide provided substantial and clinically meaningful weight and BMI reduction in adults and adolescents with overweight or obesity, and in 1 in 3 achieved a weight loss and BMI reduction of more than 20%. So Wegovy is the only anti-obesity medication with sustainable, consistent benefit in Asian people with overweight or obesity and CVD without diabetes. Semaglutide has been studied in 60,000 people across different clinical trial programs, which we are all very well aware of. So at the end, I'd like to thank Novo Nordisk for giving me this opportunity to talk about this wonderful molecule that I've been using consistently for the past almost couple of years. I thought this question will definitely come, so before anybody could ask me the question, this is there. So with this, I conclude. So which you choose? So they say absence of evidence is not evidence of absence. So the newer molecules or the generics that are currently available, they do not have the sustained data that the innovator has. So with that, I close my session. Thank you once again.
Detailed discussion about the innovator semaglutide. We can take the questions at the end, or 1 or 2 questions can be permitted now, if any questions are there.
So thank you for an excellent session. I have a question. You said that sarcopenia compared to tirzepatide is less with
Slightly lesser. Yes.
slightly lesser.
Yes.
So muscle loss is less, fat loss is more. And
No, ma'am. In tirzepatide, the muscle loss is more and the fat
Yeah.
loss is less. Yes.
less.
Ah.
Okay. So I just
1920. 19-20 comparative.
19-20.
But it is there.
it is there.
So before anybody else, I will ask one question to Dr. Swaraj. We Indians spend less on healthcare when it comes to the medicines. So this, as we know, this is a new drug in the market, and the studies all show for 12 weeks, 24 weeks. So after that the patient has lost some weight, how long do you advise them to continue? For how long it has to be continued with the medications?
Sir, antihypertensives, anti-diabetics, and thyroid medicine for hypothyroidism. So these are chronic diseases. So if I start amlodipine 5 mg for a patient, so how long will I give?
Yeah, but once the patient has lost some
Exactly.
20% of weight,
So
if
patient
it's
has lost. So once we stop, at the end of 1 year, the chances of regaining 30% of the weight loss is quite high. So for let us say the patient has used for 4 years. So at the end of 4 years, from 100 he became 80. So he might gain 6 kgs back at the end of 1 year after stopping the drug. So the chance, again it depends on how well motivated he or she is, how much of proteins they are consuming, how much of physical activity they are maintaining. So that is how it is. So as of now, it is the definition of obesity itself is it's a chronic relapsing condition of excess adiposity. So we are bridging it by giving the drug, hoping the patient will maintain. If the patient is not maintaining, then again the patient has to be on the drug. Or the other option is you can step down or decrease the dose. For example, if the patient is on 2.4, you can keep at 1.7 or 1 milligram based on the patient profile that you are seeing in your clinic. So it is a chronic disease requiring more or less a pretty longer duration of treatment.
so the financial counseling is also more important.
Financial counseling definitely.
So I had a question as well. Just yesterday, I was talking to a patient about starting GLP-1 later therapy, and their first concern was they've heard that it worsens retinopathy, so basically blindness.
Yeah, the neon thing that whatever you are talking
Huh.
about, patients with diabetes do not know that they have retinopathy. So if you don't do a retinopathy screening, so for example, let us say you did a retinopathy screening, you found that the patient is having severe NPDR. You are not supposed to start the drug.
Okay, so moderate, mild to
Mild,
moderate.
mild, no. Moderate to severe, again it depends on the duration of diabetes, the age, other comorbidities that you are looking into, and then you can take an informed decision.
And
Like,
does it change how we monitor retinopathy if we are on?
no, monitoring retinopathy is a parallel thing. So if you are having severe NPDR, do not start it. That's it. That's the easiest thing. And later, I don't think so because the patient has to go through laser and all these things. So I wouldn't suggest this drug for that classification. Sir.
Comment on that, an ophthalm opinion is a must. The ophthalmologist clearly assess the retinopathy and tell you whether they can be started or not. And the monitoring has to be every 2 months or 3 months with them also, with a professional ophthalmologist.
Hello. I think, as you said, maybe moderate or severe NPDR, you should not start at all. Mild NPDR, of course, it's questionable and it's better not to start. If there is no retinopathy, definitely it is good. But we have seen, and also in studies, it has been shown that there is no causal relationship. Because of semaglutide, the retinopathy is not occurring.
Yes.
This is probably because of the
Worsening of diabetes.
worsening, or not glycemic control. For
Diabetes,
example,
bad
if,
diabetes.
if the HbA1c is 9 to 10%, if it comes to 6.57, the
Yeah.
glycemic control, if it is faster, then it can cause increased retinopathy. That we have seen even with insulin. So we have to be careful, and of course, ophthalmic opinion is a must.
So if no more further questions, I think we'll start with the next session.
Thank you,
Thank
Dr.
you.
Swaraj, for that nice presentation of semaglutide and
Thank you, sir.
how to use it in our clinical practice.
Thank you.
I think the class of GLP-1 has had a fantastic journey so far from the innovative molecule or the very early molecule of GLP-1 which came into the market at least a decade and a half ago to today's thing, and it's been an interesting journey to take it forward. Thank you.